Yeah, so let me welcome everybody who has joined, especially from overseas. Dr. Tushar, Dr. Adrian, Lal, and who are yet to come also. And it gives us a great feel of confidence and security, when we know that so many of you are there as part of SDN in important posts. Yes, Adil. Lung ultrasound has really fascinated me for just one simple thing. Lung is always considered to be an organ filled with air, so which is useless for anybody to attempt to study that with ultrasound. And it gives only artifacts. And it was a great ingenuity of somebody who studied these artifacts and derived a lot of conclusions and points from that. That simply, that alone makes me enjoy lung ultrasound.
Hello, everybody. My name is Dr. Adil Beg. I'm a consultant intervention nephrologist in Khyber.
Dr. Adil, could you be little more allowed?
Okay. He just recovered from.
Oh, sorry. Sorry for that.
Is it okay?
Yeah.
Okay, sir.
Yes, carry on.
So I'll start. Today's topic is lung ultrasound. So I was not well for last week, so I could manage somehow to make my presentation. I'm sorry I could not make it up to the mark, but I have tried my best that I can share my experience and could explain something in the lung ultrasonography. So lung ultrasound is also known as the chest ultrasound, thoracic ultrasound, or pulmonary ultrasound. It's a point of care ultrasound application that can be used to diagnose almost any lung pathology in seconds while outperforming chest X-ray. So lung ultrasound can be performed quickly and easily in critical ill patients. It has a higher diagnostic accuracy than physical examination and chest radiography in combination. It enhances safety by avoiding ionizing radiations and need for the potentially dangerous transfer within the hospital. And lung ultrasound can also be used to guide fluid management, weaning, and therapeutic procedures also. So for the intensivists, they have many indications for the lung ultrasound, but for the nephrologist, these are not the actual indications for the lung ultrasound. So for nephrologist, so when a nephrologist get a consult from the ICU people that you have to go for the fluid management. When a nephrologist is able to do the lung ultrasound of the IVC and the focused cardiac ultrasound, so his consult becomes more scientific, it becomes more informative for him and the patient and the other persons also. So when you know how to see the wet lung, how to see the dry lung, how to see the IVC, if the patient is having the full IVC, it's not collapsing, his left ventricle's mitral valve's excursion is very less, he's having wet lung, he's having B lines. So the guidance for the fluid, guidance for the IV diuretics. In contrast to that, the patient is having collapsible IVC, a dry lung, well-aerated lung, a good excursion of mitral valve, no hepatic congestion, no effusion. So your guidance for the fluid management is better. And in patients having the chronic dialysis patients, so the chronic dialysis patients having not having the physical examination, not having the fluid overload signs, so maybe having the wet lung, so we'll guide and the IVC also. So it has been seen that we can actually go for the near the dry weight to that patients. So the major limitations of the lung ultrasound are the subcutaneous emphysema, as the ultrasound waves cannot pass through the air in the skin to evaluate the lungs. And sometimes a very obese patient, we cannot see, there's a poor ultrasound window. So the lung ultrasound pre-exam preparation. So the position of the patients, patient should lie spine or in the lateral decubitus position or may sit erect. If you are scanning on the right lung, ask the patient to lift their right arm and place their hand behind their head, and vice versa for the left lung. Like this, we can scan this area, we can scan the right area, right chest, and on the same thing on the left side. So we can sit, the patient can sit, and we can scan this area, and behind the patient, there's a posterior lung. So what ultrasound probe is used for the lung ultrasound? The big question for the early users, that we can use all the probes. We can use curvilinear probes is the best probe to do the lung ultrasound. We can use the phase array probe. We know that these are the low frequency probes. We can see in the deeper tissue by these probes, and we can use the linear transducer probe for the shallow imaging scan, the pleura close to the chest wall. We can use the linear probe, linear transducer to scan the pleural lines, to see the pleural sliding, to see the other things, but which are the superficial structures. But generally we use the curvilinear ultrasound probe. So preset should be in the ultrasound machine for the lung or the abdominal scan. Place the machine on the right side of the patient, on your right side, and then scan with your right hand and manipulate ultrasound buttons with your left hand. It's like this. So this is the patient. The machine should be on this side and probe on the right side, and the probe on the left side. Manipulate the buttons and the machine. So lung ultrasound, but anatomy, we have to see the visceral pleura, which creates the sliding motion as we breathe. We have to see the lung sliding motions. It's very important finding during an ultrasound because it can rule out the disease process such as pneumothorax. We have to see the alveoli. Alveoli exist in lobules that are subdivided by the interlobular septae. Just now, the following slide will clear this concept. The septae anchors into the visceral pleura to stabilize the lobules. When these areas fill with the fluid due to the consolidation of pulmonary edema, various artifacts manifest on the ultrasound. Actually, the ultrasound is the artifacts, what we see. So, and we interpret those artifacts and get the meaning from those artifacts. So we have a visceral pleura, we have a parietal pleura, then visceral pleura, and the lung parenchyma below that. And we have on the right side, we have a two fissures, and the left side, we have a single fissure. So this image is very important. Just below the pleura, we have the bronchioles and we have the alveoli. These alveoli and bronchiole, it is covered by the interlobular septae. So the multiple interlobular septae, when the fluid gets in these interlobular septae, we get the artifacts. So in the wet lung, we get the artifacts for the wet lung, and we get the artifacts in the aerated lung. When this is aerated, so we know that the air, it reflects everything. We get the artifacts. And when there's a fluid, we get the artifacts. This is the main concept in the lung ultrasound. So the appearance of the lung ultrasound are based on relatively amounts of the air and the fluid in the lung because of the phenomena of the acoustic impedance. So we have to understand the acoustic impedance to understand the lung ultrasonography. This is a measure of resistance of particles in a medium to mechanical vibrations. Resistance increase in proportion to density of the medium and the propagated velocity of the ultrasound in the medium. When the ultrasound hits a relatively large and the flat boundary between the medium with different impedances, some of the sound is transmitted across the boundaries and some is reflected as an echo. The greater the difference in acoustic impedance, the greater will be the reflection. Fluid has a constant acoustic impedance resulting in no echoes and it appears black. Soft tissue have a very similar values of acoustic impedance resulting in a minimal reflection. Interface between bone and soft tissue reflects about 40% of ultrasound energy, but the soft tissue and the ear reflects almost 100% of rendering, almost 100% of echoes ultrasound energy, rendering this interface virtually impenetrable to the ultrasound. So now the small concept of acoustic impedance, this will help us to understand the ultrasonography of the lung. So the resistance to the propagated sound wave through the tissue, this is the resistance actually to the propagated sound waves through the tissue. Each tissue has unique acoustic impedance. It depends on the velocity of the sound and the density of the tissue. Its units are megareals. So the acoustic impedance is equal to the density of the tissue and the sound, the velocity of the sound. Air has the least acoustic impedance and bone has the highest. And in between that, there's adipose tissues, liver, all the tissues, other tissues have the impedance between 1.3 to 1.7. So when the probe generates a ultrasound beam, it hits the first surface. This first surface is denser, so that it generates more of the equal echo as it gets the wave from the ultrasound probe. Then there is a transmitted wave and the reflected wave. When this second wave hits the different other membrane, the other surface, the deeper surface, it produces again one more echo, smaller than the transmitted wave, and again it transmits and hits the third surface, so and produces the bigger wave. So we have seen that it has produced first the smaller wave, then the bigger wave. First wave was bigger, then smaller, then the bigger wave. That means that all the tissue surface have different acoustic impedance. Acoustic impedance means their resistance is different. So they resist to the ultrasound beam which is produced by the probe. So the air or gas reflects almost all energy of the ultrasound pulse arriving through the tissue. Acoustic shadow is seen behind the gas bubbles, as we know in the ultrasound of the abdomen. So that is why the reason we use coupling agents usually between the transducer and the skin, to avoid the contact of the air so that we can see the tissues below the skin. This means structure below the pleura in an air-filled lung cannot be visualized. Only artifacts will be seen. Lung ultrasound relies on the interpretation of artifacts in conditions where the lung is predominantly aerated. These artifacts will vary depending on the ratio of the air and the fluid. If the lung is highly fluid filled, then it can be visualized directly. So pneumothorax consists of air below the parietal pleura, while a pleural effusion is only fluid. There's a range between these two extremes. That means the full air and the full water. In the normal run, we have a 90%, 98% of air. In interstitial syndromes, we have a 95% of air, like in the, interstitial lung disease. In alveolar syndrome, we have 90% of water and 10% of air. And in atelectasis, there's a collapse. There may be the active collapse, the passive collapse. We have the 5% of air, all with different ultrasound appearance ranging from a specific artifact to a true structure visualization. It's important to remember that because of the gravity, fluid is usually dependent and air is non-dependent. So these are the surface markings, surface anatomy of the lungs and the lobes. We can see on the anterior side, we can see the anterior right upper lobe. We can see the left upper lobe, right middle lobe, and the right lower lobe. But on the lateral side or behind the chest, we can on the back side, we can see the right lower lobe and the left lower lobe. On the side, on the upper part, we can see the right upper lobe, and on the lower side, we can see the right lower lobe, same for the left side also. So we have to scan at the 3 areas on the right side and 3 areas on the left side. So we have to scan for the 6 points. We have designated them R1, R2, and R3, and L1, L2, L3 respectively. So when by R1, we can see the upper lobe. In R2, we can see the middle lobe and the posterior lobe by the R3 point, same as in the left lung. But when we have a suspecting the viral pneumonia, we have suspecting more diffuse disease in like in patchy pneumonia. So we can have a 6, in spite of 6, we can have a 12 point. So R1, R2, R3, R4, and R5, R6. So 6 on the one side and 6 on the opposite side. So we can have a 12-point examination also in the more diffuse disease to get the better diagnostic utility. So this is like the probe in the R1 position, probe in the right R2 position, and probe in the R3 position, and same on the left side. So we have a 6 points, 3 points on the right and 3 points on the left side. So point number 1, we have R1 or the L1, assess the anterior chest wall. This point will be the most relevant when assessing for the pneumothorax or the interstitial edema. This point your indicator towards the patient's head. This is the first point. Place your probe at the mid-clavicular line at the second intercostal space of the right side and the left side of the lung, respectively. Anchor your probe in the space between the two ribs. These are the important. One indicator should be towards the head. Second, at the R1 in the second intercostal space, L1 in the left side on the second intercostal space, and the anchoring of the probe between the two ribs. Like this, it should be towards the head and the mid-clavicular line, or left side or right side in the second intercostal space. So in between, the probe should be in between the ribs. So this sign will get, after putting the probe, we'll get this sign. So this sign is known as the bat wing sign. So identifying two rib shadows or bat wing sign. This is the first lung ultrasound finding to confirm the correct position to look for the two rib shadows. This is also known as bat wing sign. This ensures that the probe is in between the two ribs. This is the most important sign to get in the ultrasound of the lung. So this is the subcutaneous tissue. And then below that is the rib shadow. That's a rib, one rib, and the second rib is a bone. And then in between is the intercostal muscles. And below that is the pleura. The pleura line is the hyperechoic line. And from there, we get shadows from the bone, the rib shadows, one rib shadow and second rib shadow. So why this is known as bat wing sign, because this, on the ultrasound of the lung, that this rib shadow appears as a wing of bat, this second wing of bat, and this is the body of the bat, and this is the lung tissue. We'll see this. This is the short video. It's the short video that we see. This is the one. This is the shadow of the rib. This is the surface of the rib. This is the surface of the rib. This is the shadow of the rib. On the opposite side, this is the shadow of the rib. In between, there's a subcutaneous tissue, intercostal muscles, and this is the pleural line. This is the pleural line. So we can see, this appears as this is a pleural line. This is the shadow of the rib. This is the surface of the rib. This is the surface of the rib. This is the one wing of the bat and second wing of the bat. This is the body of the bat. So it appears that the bat is coming towards you. So you can see the picture. This is known as bat wing sign. This appears as a bat wing sign. This is the body of the bat. This is the wings of the bat. This is the most important sign to look for in the ultrasound of the lung. The same thing. This is the pleural line. This is the rib. This is the surface of the rib. This is the surface of the rib. This is the shadow of the rib. Shadow of the rib. In between is the pleural hyperechoic line. This is a pleura. So this is the body of the bat. This is the wings of the bat. So next is the lung sliding. It's a normal finding where the visceral and the parietal pleura slides back and forth on one another as the patient breathes. Some says this looks like ants marching on the line. This is also known as pleural pulsations. It appears that the pleura is pulsating and goes to and fro. This is a simple finding, but extremely useful, since lung sliding definitely means that the visceral and the parietal pleura are next to each other, it effectively ruling out the pathology such as pneumothorax. So this is the rib, this is the rib surface, this is the shadow of the rib, and this is the subcutaneous tissue, this is the muscle, this is the pleural line. So this is pleural line. It appears that this is pulsating and this is moving. When this is pulsating, this is moving, going below the ribs. This means the lung is sliding against pleura. This pleural sliding. This is known as lung sliding. That means there is no pneumothorax. So we can see if there is a poor visualization of the lung sliding, so we can see it by the M mode. So there's one more sign, this is known as seashore sign. So it appears when we put this M mode, we can see a skin is a static organ. So it's static, so it gives no movement. It appears like a sky. And ocean muscles, it's also static thing, that it doesn't give any movement, but only movement the lung slide, the pleura, it goes to and fro, and it gives a motion like thing on the M mode, and it's known as sandy appearance. So it's known as seashore sign. So this is created by the sky, is created by the subcutaneous tissue. This is by the muscles. And this beach-like thing, it appears that there is a sand. There's a sand-like thing. There's a movement. There is no movement. Then no movement. It's an ocean, and this is the sky. This is known as seashore sun. So this is a short video. So this is the rib. This is the rib surface. This is the pleural line. This is the pleura. It's moving. There's a lung sliding. When we get the M mode, so we'll see there is no movement of this, no movement of this, but there's a movement of the pleura only. So this is the sky, this is the ocean, and the beach is known as seashore sign. So now we have to identify the A lines. When the probe is angled perpendicular to the pleura, ultrasound waves reflect off the air from the pleura and probe surface, producing an image what look like pleural lines that lie equidistant to the true pleural line. These reverberation artifacts can continue reflecting back and cause several A lines to appear before dissipating. So we can get the first A line, second A line, and third A line. So clinically, the A lines can indicate healthy aeration of the alveoli. However, A lines can also be seen in cases of pneumothorax, but there will be no pleural sliding in the pneumothorax. So there will be reflection of the air in the parietal pleura, but the lung sliding will be absent in the pneumothorax. So this is the probe. When it produces the ultrasound beam, it is reflected, everything is reflected. It will not allow anything, aerated lung will not allow anything to pass it. So it will, all the reflected beam, it goes to the probe, and it will give the equidistant lines. A1, A2, A3, they are equidistant, they are similar as the pleural line, though these are known as the A lines. A line means that the lung is aerated. If this is the pleura, it gives the equidistant lines which fade when we go down. When we go down the line, this fades, but they are equidistant. That means there is this reverberation artifact. That means below the pleura there is the aerated lung. There is no fluid in the lung. This all alveoli, they are filled with air. Again, the same thing, that there's a pleural line, there's an equidistant one, second, and third, they're equidistant, but they fade when we go down. And the second step is the lung ultrasound of the lateral chest. That means the position at the R2 and L2. So point 2 means R2, L2 examines the lateral chest. Place the probe at the right on the R2 or the left mid-axillary line around the 6th and the 7th intercostal space. This should be just lateral to the nipple line in the males. Anchor your probe between the two ribs, and just like in point 1, look for the batwing, lung sliding, and the A lines like this. So it's a 6th, 7th, 8th intercostal space in mid-axillary line. In mid-axillary line, so we can see this means that we are seeing the middle lobe. Similar way, we have to go to the left side. And step 3, it's a lung ultrasound of the posterior chest, R3, L3. It's also known as PLAPS. That means that the posterior and the lateral alveolar and pleural syndrome, this is the point where we can see the consolidation, we can see the effusion. So it is to assess the posterior chest. The point is commonly known as the Plapp's point on the lung ultrasound. That means the posterior or the lateral alveolar or the pleural syndrome. The Plapp's will be most relevant for assessing the presence of the pleural effusion and the consolidation. Point the probe indicator towards the patient's head, as we know. Slide the probe under the patient at the Plapp's point, means R3 and L3, at the intersection of the posterior axillary line, rib space between the 10th and the 12th. Like this is the 10th, 12th rib. Place the probe indicator towards the head. In between the ribs, anchor the probe firmly over the skin. So we can identify the liver on the right side and the spleen on the left side, kidneys and diaphragm on the both sides. These organs will come in and out of the view when the lung inflates and deflates. We should also see the spine, which in healthy lungs extend up only until the border of the diaphragm. We'll go with this concept also. So if it extends past the diaphragm, it's called as the spine sign. See, this is the diaphragm, this is the liver. So the below diaphragm, there's a spine, but we can see the spine only here. We cannot see the spine here. Why? Because the ultrasound beam, it's all reflected. It's all reflected by the lung. If there is an aerated lung, there will be no spine visible beyond the diaphragm. No, beyond the diaphragm, there will be no spine. When this is collected with filled with fluid or with the consolidation, we can see the spine. This is known as the spine sign. So we can also see the lung tissue. This is the lung tissue. This is the diaphragm. This is the liver. This is the kidney, and the spine only up to the diaphragm, not beyond the diaphragm. Sometimes what happens that we can see this picture. So this we can see spleen, and the same thing on the opposite side. On the above the diaphragm, we can see the liver, and the same thing on the below the diaphragm. This is known as the artifact. This is the mirror artifact. What happens actually on the angled surfaces? There's a refraction of the waves, and there appears the same thing. But for the lung ultrasound, we have to see that there should be the pleural line, pleural sliding. We have to confirm that. So sometimes there's known as something called as curtain sign. The curtain sign is seen in healthy and aerated lungs at the R3 or the L3 point. So an aerated lung is like a curtain, because as it fills with air, it looks like a curtain sweeping down and over the other organs, momentarily obscuring them from the view. The diaphragm, liver, and spleen reappears during the exhale. What happens? This is the diaphragm, and this is the diaphragm. When the lung comes like this is the pleural line. Lung comes like this and goes back, comes like this and goes back. This is known as the curtain sign. Also, this is the indicator for the CP angle. So the costophrenic angle, this is the costophrenic angle. This is the diaphragm, this is the liver, and this is the lung tissue, which comes and goes. If there is accumulation of the fluid, this is the most dependent part of the chest. So the fluid accumulates here. If there is a space between the diaphragm and the lung is a hypoechoic space, that means this is effusion. But when you get this picture, there's a compact structure, lung, there's a pleural sliding and pleural lung sliding. There's a pleural line compactly with the diaphragm and the liver. There is nothing in between them. That means the CP angle is clear. So mirror image artifacts we have already discussed. Sometimes we get the same image above and the below diaphragm. This is not the lung, this is the mirror artifact of the liver. So we have to get that image, that there should be a lung, pleural lung sliding. That is the actual lung. This is not the lung. So there are some signs and the findings in the lung ultrasound. So the lung ultrasound pathology profiles from pneumothorax, pneumonia, and cardiogenic pulmonary edema. will have different combinations and distribution of these pathologic lung findings or signs. So first is absent lung sliding. So lung sliding may be reduced or absent in a variety of circumstances. There is no lung sliding present when the parietal and the visual pleura become separated by an ear, which we call pneumothorax, or the fluid, which we call the pleural effusion. In severe COPD or anything that hyperinflates the lung can markedly reduce this lung sliding, as it knows. There's a bullae, there's an air-filled bullae, so it will obscure the lung sliding. Absence of lung sliding can be seen using the V mode or using the M mode, and which gives the Strasser sign or the barcode sign. If there is a pneumothorax, there is no movement of the lung, there is absent lung sliding. This is, for example, this is not moving. This is the absent lung sliding there because there's air behind it. So it's not moving. Everything is reflected. And there is no, because there is no contact of lung and the pleura. It gives a barcode sign. There is no movement of the subcutaneous tissue, no movement of the muscles, and no movement of the pleura. So it gives the same thing. What we call as seashore sign is the opposite of that. That's known as barcode sign. So in pneumothorax, we'll get a barcode sign. The most clinically relevant fact about lung sliding is that if lung sliding is present, you can rule out pneumothorax with 100% sensitivity. On the flip side, the absence of the lung sliding can have many causes, like pneumothorax being one of them. So there can be some other causes, that the acute respiratory syndrome, there can be severe COPD, there can be bullae. So second is interstitial edema or the syndrome and the B lines. The next concept is a very important concept in the lung ultrasound. The lung interstitium, or the network of the tissue that supports the alveoli, as we saw, and blood vessels can thicken and fill with the air. The bronchiole, it gets filled with the air. And B lines form when the interlobular septa and the lung tissue thickened or filled with the fluid. Thus, many clinicians have equated B lines with the wet lung. Remember, A lines are horizontal while B lines are vertical. This is very important. The quality of B lines are, they appear ray-like, they are hyperechoic, they are vertical, they arise from the pleural line, they move with the lung sliding, they extend to the periphery of the far field, they can be associated with the thickened pleural membrane. Patient with chronic scarring of their septae by pulmonary fibrosis, old infection, interstitial lung disease, have chronically wide and thickened septa that also create B lines even without a wet lung etiology. So we have to differentiate the lungs. We have to go for the IVC and other things to see the pulmonary edema. Lung fissures between the lobes can produce single B lines, but less than 3 B lines is in a single field of view is generally considered normal. So there is something called as confluent B lines. As more fluid builds, they become more dense. It will become increasingly difficult to differentiate between the singular B lines. Thus, as more and more B lines converge, they can create an appearance of the confluent B lines. So these are the few B lines, 1, 2, 3 B lines. They arise from the pleura. They are vertical. They are cutting the A lines. They go from pleura to down far field. They are hyperechoic, and they are more than or equal to 3. And they move with the lung sliding. They move the pleural sliding. When they become more and more B lines, they are more wet tissue, filled with the alveoli and more filled with water. So this is the rib shadow, this is the rib surface, this is the rib shadow, and this is a pleural line. From it, there's a confluence of the B lines. So we cannot differentiate one single B lines, but we can differentiate this a single B line, but there's a confluence of the B lines. That means the tissue is more wet. So this is the B lines. This is the B lines. They arise from the pleura. They are equidistant. They are A lines. So we can see this. These are the B lines. They arise from pleura. They're equidistant. They're vertical. And these are the, in comparison, they are the well aerated lung. This is the pleura, and they're the equidistant lines. This is known as A lines. So consolidation, as fluid builds up in the lung, part of the lung can become completely fluid filled, leading to consolidation. This is commonly seen in pneumonia. As fluid builds up progresses, ultrasound finding will progress from multiple B lines, then confluent B lines, and subpleural consolidation. That's known as Schrader sign. The subpleural consolidation gives a sign, is known as Schrader sign. We'll see that, to a dense consolidation. Once the air is completely gone from the lung and replaced with the fluid, this will result in an echogenic structure on the ultrasound, similar to the echogenicity of the liver. It appears that the lung is termed as, now that's a hepatization of lung. Then lung is it look like liver. So this is the rib border. This is the margin of the rib. This is the surface of the rib. This is the shadow of the rib, and in between is the pleural line. This is the muscles, pleural line, and there's a small subcutaneous subpleural accumulation of hypoechoic material with the echogenic material below that, and few B lines. So this is known as Schrader sign. There's a small subpleural consolidation. You can see clearly this is the rib surfaces, these are rib shadows, and there's a small, we can see only the small portion of the lung sliding or the pleura, and below it is the accumulation of the hypoechoic material with, and this can be the B lines, or this is a air filled, this is a bronchogram. So this is known as Schrader sign. This is a subpleural consolidation. Now then the lung, how the dense lung consolidation will be seen. When the lung is completely filled with fluid, it's completely collapsed, it's atelectatic. There's a dense appearing lung consolidation. It's a hepatization of lung. It looks like this is a rib, this is the rib shadow, and there's a lung. This lung, it looks like it. This is the ear. It looks like a liver. So this is the fluid-filled lung with the trapping of the ear in between. So this trapping of the ear can be of two types. It can be dynamic bronchogram, or it can be static air bronchogram. When there is a collapse, when there's a collapse of the bronchi, so this air does not move with the respiration. When this does not move with the respiration, it is known as atelectic lung. That is a collapsed lung, it is a consolidated lung, or it's a fluid-filled lung, or it's a compressed lung with the air in between. So it's a static air bronchogram. That means it's a atelectatic lung. This is the atelectasis. And when there's a movement of these air bubbles, when there's a to and fro movement with the respiration, that means that the bronchi is open. That means it's a consolidation. It's not the atelectatic lung. So consolidation can also present with the static or dynamic air bronchogram, what we already discussed. On ultrasound, this is trapped air appears as small hypoechoic specks. Dynamic air bronchogram occurs in pneumonia and moves as the patient inhales and exhales. Static air bronchogram occurs when an air bubble are trapped behind an obstruction, as occurs in atelectasis, and don't move with the respiration. Now, the important thing is pleural effusion. So when the pleural effusion occurs, when exudates or the transudate built up in the base of the lungs, they are best viewed from the P3 point. If there's a PLEPS point, means R3 or L3 point, where the lower lobes are viewed. Point of care ultrasonography is over 90% sensitive and specific for detection of the pleural effusion. Even a small amount of effusion we can see. So this is the diaphragm, this is the liver, this is the subcutaneous tissue. So we were expecting here the pleural line, but there's an accumulation of hypoechoic material here, fluid, and this is the lung. This is the lung. This is the consolidated lung, because we are seeing some air bubbles in it with the collapsed lung. So this can be partial collapse, this is the passive collapse, this can be the active collapse. So this, we can see the spine sign. So from here, we cannot, in the aerated lung, beyond this thing, we cannot see the spine, but here we can see the spine. This is known as spine sign. We can see the spine also as the rays are going, and we can see the spine also. So how to calculate the pleural effusion size? So it's a pleural volume in ml. It's measured the distance in mm between the maximum points into 20. So we can see here is the maximum distance. So from here to here, we have to measure. For example, it is 30 mm. So we have to multiply it with the 20. So we get the 600 ml of effusion. So pleural effusion, it gives multiple signs, but these signs tell us that there is a effusion. One, it confirms there's a effusion, and the pathology, underlying pathology. So we have a spine sign. We already discussed that. Jellyfish sign, sinusoidal sign, cord sign, plankton sign, hematocrit sign, and loculated pleural effusion. I will go fast with these signs. Already we have discussed that there's the diaphragm, there's a liver. We can see the effusion, and we can see the spine beyond the this diaphragm. So this is known as spine sign. In jellyfish sign, we get the liver, like this tip of the lung, which moves in the pleural effusion. It's known as jellyfish sign. When jellyfish sign will get the M mode of this jellyfish sign, there is a movement of the lung. This is the movement of the lung. This is the tissue, subcutaneous. This is some fluid. This is static, and there's a movement of the lung. This is known as sinusoidal sign. This is known as sinusoidal sign. Then there's a cord sign. So this is the there's a subcutaneous tissue. There's a pleural line, and in between there's a parietal pleura. Then there's a visceral pleura. We have the two rib signs. In between there's a cord-like thing that's known as cord.
Dr. Adil, it would be great if you could wrap up soon, because we are running behind the schedule.
There's a few slides now.
Yeah.
So now the plankton sign. In exudative, we have the multiple plankton sphere-like structures, and in the effusion, they are traveling like here and there. This is known as plankton sign. And hematocrit sign, when there's a layering of the effusion, it's known as the hematocrit sign. And then when we have this is the diaphragm, this is the lung, and there's a multiple septi in between. This is known as loculated effusion sign. So in conclusion, in addition to the diagnostic renal sonography, assessment of volume status is an important application of focus in the practice of the nephrology. Lung, inferior vena cava, and focused cardiac ultrasound are relatively easy to learn and immensely useful tool for nephrologists, especially in the care of end-stage renal disease patients. And for example, B lines in the lung suggestive of increased lung water are detected in end-stage renal disease patients, even in the absence of such symptoms such as dyspnea and or the pleural peripheral edema. Similarly, data suggests that the inferior vena cava measures by the sonography are accurate to predict the high or the low central venous pressure in the dialysis patients. Thank you. It's open for the questions. Bala sir.
Thank you, Adil. I realize we need actually more time, but for the audience, I think clear understanding of B lines and A lines for now. I think if that messages and that tricks has reached them, I think it was that is more than enough for now.